Hello, my name is Dr. Nathan Fowler from the MD Anderson Cancer Center. And I'd just like to discuss a very interesting case that we saw in our clinic recently. And I think this case represents a dilemma that a lot of folks see in the community. And that's what to do with a patient with transformed follicular lymphoma. So I'm going to kind of start at the beginning and just kind of tell you about how this case presented, as well as kind of what we did and why we chose the therapy that we did. So this was initially, well, it still is, a 59-year-old male who presented to his primary care doctor with bilateral cervical adenopathy. No night sweats, no fevers. He had noted that these nodes had been present for about 6 months. He eventually went and saw his primary care doctor, who referred him to an otolaryngologist, and they got a biopsy, and the biopsy showed a follicular lymphoma. As you can see here, the cells were positive for CD20, CD10. Most of the cells were small with irregular cleaved nuclei. The immunohistochemistry was also positive for CD22 and BCL2. And we did flow cytometry, which was fairly consistent with the low-grade lymphoma, with the cells being positive for CD20 and CD10. He had a bone marrow biopsy, which showed about 20% involvement by these similar cells with approximately 60% cellularity. This is his PET scan. We also did CT imaging, and as we expect in patients with newly diagnosed low-grade lymphoma, he had stage 4 disease with involvement in the marrow, as well as several small nodes which were involving the neck, the axilla, the abdomen, as well as in the chest. Most of these nodes, again, were fairly small volume, around 1 to 2 centimeters, and he was asymptomatic. So I think that kind of brings the first question about what to do with these patients. And this is probably about 10 to 20% of the patients that we see in our clinic, folks that present with low volume disease and not a lot of symptoms. When we see these patients, I often refer to several British studies which have suggested that early intervention has not shown a benefit in overall survival in patients with low-grade lymphoma. And what that means is not that I think that we can obtain a longer progression-free survival, longer remission with early treatment, but starting treatment early, at least with today's drugs, has not been shown to make patients live longer. So generally in my practice, in patients that have low volume disease and do not have bulky lymph nodes, I generally will watch them at least for a short amount of time, and that usually means around 3 to 6 months with reevaluation to see the rate of progression. So this gentleman was, again, asymptomatic. He was doing well, so we decided to watch and wait. I saw him in serial visits over the next 2 years, and he did quite well. However, about 24 months after our first visit, he developed evidence of some night sweats, fatigue, and he had some vague abdominal pain. We did repeat imaging, and on repeat imaging, as you can see here on the PET scan, he had similar nodes. However, there was a new mass in the kind of mid-abdomen, the mesentery. I sent him down to our interventional radiologist. He had a core needle biopsy of this node, and as we were suspecting, he had transformation of his low-grade lymphoma. The cells were positive for CD10, but there were sheets of large cells with Ki-67 of around 60 to 70%. Our pathologist, along with my colleagues, reviewed the pathology and felt, again, this was consistent with a transformation of this gentleman's underlying low-grade follicular lymphoma. So I think this is a kind of a nice point to talk about low-grade lymphomas and how often they occur. Generally, in patients, most studies have shown in patients with newly diagnosed low-grade lymphoma, the odds of a transformation are about 2 to 3% per year. And this is additive, so if patients have low-grade lymphoma for 10, as high as 20 years, the risk of a transformation is probably somewhere around 20 to 40%. Now, if you suspect transformation, this is not a clinical diagnosis. I do use clinical presentation to kind of help me make the diagnosis. However, you need a biopsy if you suspect transformation. Generally, biopsy, as we saw in this patient, will show increased large cells. The Ki-67 is generally higher. The immunohistochemistry should be the same, i.e. CD10 positive, CD20 positive. And patients often will have increased SUV on PET imaging. Unfortunately, most studies have failed to show a benefit of early intervention with regards to preventing transformation risk. So this is, I think, a very important concept. I think in the past we felt that possibly using more aggressive treatment early could decrease the risk of transformation. At least in retrospective studies, this has not been shown to be true. There are some recent studies from the Mayo Clinic suggesting that maybe early intervention with Rituximab could decrease transformation risk, but as of yet, few randomized studies have been able to show a benefit to early intervention, reducing the odds of transformation. As I mentioned, as you can see from this slide, the risk of transformation is fairly linear. It goes up about 2 to 4% per year, and most studies show this probably peaks at somewhere around 40 to 50%. Unfortunately, in the past, patients that transform with follicular lymphoma don't do well. And I think this is highlighted by the Stanford experience, which showed that this is, again, in the pre-Rituximab era, patients generally didn't do well. This is with salvage chemotherapy, but the average overall survival following transformation only about 4 to 5 years. So clearly, I think there are improvements that can be made in this patient population. Since the advent of Rituximab, most of these folks will get Rituximab. In my practice, I usually combine it with chemotherapy that's targeted towards large cell lymphoma. This would be Rituximab with CHOP, possibly Rituximab plus EPOCH chemotherapy. If patients have previously received one of those regimens, I'll sometimes then give them rice chemotherapy or another salvage therapy, which is effective in large cell lymphoma. Unfortunately, there's no randomized studies to tell us which is the best approach for salvage therapy. So often this is kind of in the hands of the clinician to decide what he's most comfortable with. And I'll show you a little bit of data about some retrospective studies in a second. One of the questions I get often from colleagues in the community as well as other academics is what is the role of stem cell transplant in this population? I think in the past, again, at least in the pre-Rituximab era, there was data suggesting that these folks tended to do worse than de novo large cell lymphoma. And trying to change that natural history, many patients were referred to transplant. So there are several retrospective studies looking at the outcomes of patients with autologous stem cell transplant as well as donor allogeneic transplant with transformed follicular lymphoma. One of the largest was recently published in Leukemia and Lymphoma Journal by Peters et al. And here they looked at the outcomes of patients with transformed lymphoma who had autologous stem cell transplant at transformation. And you can see from the graphs that patients actually did fairly well. If you look at the EFS, which is the event-free survival, or patients that are in remission, around 60% of them remained in long-term remissions following autologous stem cell transplant. And if you look at the x-axis, many of these patients were followed up to 10 years and remain in remission. I think this data is especially impressive if you look at patients' response to last therapy. Now, clearly patients that refer to autologous stem cell transplant are a population that are generally not doing well, maybe have inferior outcomes to their last therapy. So it's not surprising that patients' event-free survival to their last regimen, or the remission rate to the last regimen, was about a year to year and a half. And as you can see by this curve, it was dramatically different when they went to autologous stem cell transplant, suggesting that autologous transplant was possibly changing the natural history of transformed follicular lymphoma. Okay, so the next question is, what about allogeneic transplant? This is a approach that we've used quite a bit at MD Anderson in patients with follicular lymphoma. I personally believe that allogeneic transplant in a subset of patients is potentially curative. Now, in transformed lymphomas, there have been retrospective studies comparing autologous transplant versus allogeneic transplant. One of those was just recently published in Cancer last year by Evans et al. And from this multi-center study, this was a NCCN cooperative group collaboration, they looked at patients with transformed follicular lymphoma. They had almost 190 patients who received autologous as well as allogeneic transplant. And the progression-free survival was nearly identical between the two groups. However, mortality was significantly higher in patients that received allogeneic transplant, and as we would expect, relapse rate was higher in patients that had autologous transplant. So it kind of goes back to the outcomes following each of these modalities slightly different. Long-term, progression-free survival was quite similar. Relapse rates were higher with auto, but mortality was higher with allogeneic transplant, and most of these were matched unrelated donors. So I just want to kind of finish up talking about what about Rituximab plus chemotherapy. There have been a few studies suggesting that Rituximab plus chemotherapy in this patient population is a very viable option. The Canadians looked at allogeneic versus autologous as well as Rituximab plus chemotherapy, and surprisingly, they showed that, again, retrospective study, the outcomes were fairly similar between patients that had autologous transplant, allogeneic transplant, or Rituximab plus chemotherapy, and the vast majority of these patients were getting R-CHOP. I think that that study was followed up by another retrospective study by Link et al., and here they looked at just the outcomes of Rituximab plus chemotherapy, basically R-CHOP in patients that received Rituximab, R-CHOP in patients that had transformed follicular lymphoma. And as you can see by this graph, outcomes were surprisingly good with just R-chemo, so R-chemo without consolidation using transplant. And if patients had transformed beyond 18 months, survival as well as event-free survival quite good, as well as patients that had not received R-chemo in the past, their outcomes were very good and very similar to patients who had de novo large cell lymphoma. So I think, in conclusion, transformed follicular lymphomas remain a dilemma. There's very few randomized studies to tell us which way to treat patients. In my own practice, if patients have transformed follicular lymphoma and have not received an anthracycline in the past, I generally will use R-CHOP. If they've had R-CHOP in the past, I generally refer them to allogeneic or autologous stem cell transplant. And I think the decision between the two transplants really is between the patient, the lymphoma doctor, and the transplanter, and with a really detailed discussion about the risks and the benefits of each of the modalities. So I hope that that was informative, and I hope that we'll have further studies in transformed follicular lymphoma in the future to help guide us as to what's the optimal therapy. Thanks.